Hi everyone, and welcome to our module on esophageal disorders. In this video we'll talk about a number of esophageal disorders, but let's start by talking about some of the symptoms patients can develop when there's something wrong in the esophagus. Odynophagia refers to painful swallowing and dysphagia refers to difficulty swallowing, and these two symptoms are common to many esophageal disorders. When patients have dysphagia, it's important to determine whether the problems swallowing are related to liquids, solids, or both. When patients report dysphagia to both solids and liquids, this usually indicates a motility disorder. This usually means there is some problem with peristalsis in the esophagus. In contrast, when patients report dysphagia to solids only, that usually indicates a structural disorder that has narrowed the lumen of the esophagus. When the lumen of the esophagus narrows because of some structural problem, that will cause solids to become obstructed, leading to dysphagia for solids. But liquids will usually flow past the obstruction, and therefore patients with structural disorders usually report dysphagia to solids only. And so these last 2 points here are very high yield. These are major principles of the evaluation of esophageal disorders. Let's start by talking about acute onset dysphagia. This refers to the sudden inability to swallow food. And when patients develop the abrupt sudden onset of the inability to swallow food, usually this is because they have impaction of food in their esophagus. Certain types of foods, especially if they're not chewed well, are prone to obstructing the esophagus, and this will lead to the sudden onset of dysphagia. The most common foods to do this are meats like beef, chicken, and turkey. Shown on the slide is an endoscopy with a picture of meat impacted within the esophagus. This diagnosis is usually made clinically in a patient who has the acute onset of dysphagia while eating foods like meats. The management involves IV glucagon, which relaxes the lower esophageal sphincter. This will sometimes help the food to pass. And then often upper endoscopy is required to identify the obstructing food and then to pull it out of the esophagus. In contrast to acute onset dysphagia, non-acute dysphagia develops slowly over time. And we break down non-acute dysphagia into 2 subcategories. The first one is oropharyngeal dysphagia, and the second one is esophageal dysphagia. Oropharyngeal dysphagia refers to difficulty initiating swallowing. Patients with oropharyngeal dysphagia will report that when they try to begin swallowing, they start to choke or sometimes they begin to cough. In some cases, oropharyngeal dysphagia can lead to aspiration of food into the lungs, and this can lead to even more coughing. Patients also often report a globus sensation, which means a feeling of a lump in the throat. And there is a long list of neuromuscular and structural causes of oropharyngeal dysphagia. These are all related to the nerves and muscles of the oropharynx, which have to work together to push a bolus of food into the esophagus. The first step in workup of a patient who has these types of symptoms that are consistent with oropharyngeal dysphagia is usually to order a barium esophagram. This is also called a barium swallow. This is a picture of one on the screen. It uses a fluoroscope to take an image of the patient's oropharynx as the patient swallows some contrast. And if there's a portion of the oropharynx that is dysfunctional, leading to the oropharyngeal dysphagia, it can usually be identified by barium esophagram. In contrast to oropharyngeal dysphagia, in esophageal dysphagia, food becomes stuck a few seconds after swallowing. Patients will often report a sensation of food being stuck in their upper esophagus after they swallow food. And there are many causes of esophageal dysphagia. These include things like motility disorders, esophageal malignancy, esophagitis, and also strictures. And we'll talk about many of these things later in this video. But in general, when patients have esophageal dysphagia, the workup usually begins with an upper endoscopy. This involves inserting a camera into the esophagus, and this allows you to visualize the esophagus to make sure it's structurally normal. The first thing you want to do is see the esophagus and make sure there isn't a tumor or a stricture or some other structural cause of the patient's esophageal dysphagia. Now let's talk about esophageal motility disorders, which can cause esophageal dysphagia. There are 3 important motility disorders: achalasia, hypertensive peristalsis, and diffuse esophageal spasm, and we'll talk about all 3 of these in the next few slides. They all present similarly with dysphagia to solids and liquids and with heartburn. And as I said earlier, when patients present with dysphagia, usually the first test that's done is an endoscopy. But after endoscopy, the next best test for all of these motility disorders is usually an esophageal manometry test. This involves placing a probe into the esophagus and then asking the patient to swallow, and the probe notes the pressure changes in the esophagus as the patient swallows. Shown on this slide is an example of the results of an esophageal manometry test. You can see that in the pharynx, initially there's very low resting pressure, but then the pressure goes up and down as the patient swallows. At the level of the upper esophageal sphincter, the pressure falls when the sphincter opens, and then it climbs back up and goes back to a resting level. And then in the different levels of the esophagus, the upper, middle, and lower level, we see these waves of peristalsis where the pressure rises in the upper esophagus, followed by a rise in the middle and the lower esophagus. And then lastly, down at the lower esophageal sphincter, there is a resting pressure. The pressure falls when the sphincter opens and then comes back up to the resting level. So these data are very helpful in evaluating patients with motility disorders. The results of esophageal manometry are different for achalasia, hypertensive peristalsis, and diffuse esophageal spasm, and we'll see some examples of that in the next few slides. Our first motility disorder we'll discuss is achalasia. In achalasia, there's an inability to relax the lower esophageal sphincter, and this leads to a loss of lower esophageal peristalsis. The cause of achalasia is a loss of ganglion cells in the myenteric plexus associated with the lower esophageal sphincter. This is thought to be due to inflammation, so basically achalasia is an inflammatory disorder where these neurons get destroyed. The cause of achalasia is often idiopathic, but it can occur as part of Chagas disease, which is a protozoal infection with the protozoa Trypanosoma cruzi. When the lower esophageal sphincter will not open, patients develop dysphagia to solids and liquids. And remember what we said before, dysphagia to both solids and liquids usually implies a motility disorder, and achalasia is a motility disorder. Patients can also note regurgitation of food, and they can have retrosternal burning similar to gastroesophageal reflux disease. This is caused by irritation of the esophagus from retained food. And then lastly, patients can develop bad breath. That's from the accumulation of food in the esophagus. In patients in whom you suspect achalasia, the workup usually begins with endoscopy. As I said earlier, for many patients with dysphagia, we begin the workup with endoscopy because we want to rule out a structural cause of the dysphagia. If you do endoscopy in patients with achalasia, you may see retained food in the esophagus, and sometimes you cannot pass the scope beyond the lower esophageal sphincter because the sphincter has such high resting tone. But other than these two findings, often what you see on endoscopy is simply a normal esophagus, and that's helpful because it rules out other causes like cancer. After endoscopy, the test that's usually done is an esophageal manometry test. This is required to establish the diagnosis of achalasia. It will show a couple of findings that make the diagnosis of achalasia. First of all, there will be aperistalsis in the distal esophagus. This means that as you get closer to the lower esophageal sphincter, there will be a lack of peristaltic waves because the neurologic activity is missing. You also can see incomplete lower esophageal sphincter relaxation, and there can also be elevated resting lower esophageal sphincter pressure as well. So if you look at this esophageal manometry result on the screen here, once again I've shown normal, but here I've shown what you would see in achalasia. And everything is basically the same as normal until you get to the middle and lower portion of the esophagus. And these peristaltic waves, which are normally high like this, have become flattened. That's aperistalsis of the distal esophagus. And then once you get down to the lower esophageal sphincter, there should be a wave like this indicating relaxation of the sphincter. Instead, you have this little tiny wave that indicates incomplete lower esophageal sphincter relaxation. And then in addition, note that the resting lower esophageal pressure is normally here, but in this example on the screen, it's much higher. That's higher resting lower esophageal sphincter pressure. And so usually the way the diagnosis of achalasia is established is by findings like these on esophageal manometry. An alternative to manometry is a barium swallow. It will show dilation of the esophagus, and the classic finding is called the bird's beak. This is a picture of this shown on the screen here. You've got narrowing of the distal esophagus and the lower esophageal sphincter from achalasia, and then upstream of that you have dilation of the esophagus, and that's the bird's beak finding. For most patients with achalasia, the treatment is either with pneumatic dilation or myotomy, either through surgery or endoscopy. This is a picture of pneumatic dilation on the screen here. You put a balloon across the lower esophageal sphincter, and then you inflate the balloon to try and stretch the lower esophageal sphincter. For myotomy, you simply make an incision in the lower esophageal sphincter to try and decrease the resting tone. That can be done as an open surgical procedure or with the endoscope. When patients have pneumatic dilation, there is a risk that the esophagus could rupture, requiring surgery. So even though this is a less invasive procedure, patients have to be good surgical candidates in case they have a complication. For patients who are poor surgical candidates and can't have one of these procedures, there are some other options. You can inject botulinum toxin into the lower esophageal sphincter via an endoscope. Patients can also be treated with sublingual nitrates before meals, which will relax the lower esophageal sphincter. Our next esophageal motility disorder is called hypertensive peristalsis. It's also called nutcracker esophagus. In this condition, patients have excessive amplitude or duration of contractions of the esophagus. Basically, the esophagus works normally, but it squeezes too hard, and this leads to dysphagia for solids and liquids. Just like with achalasia, patients can also have retrosternal burning similar to GERD. The workup begins like a typical dysphagia workup with endoscopy, but that will be normal in nutcracker esophagus. And then the diagnosis is established by esophageal manometry. It will show a normal sequence of esophageal contractions, but high pressures from contractions being too strong. This is a picture of what it looks like on the screen here. The patient begins to swallow, and you see these contractions that are very, very high, getting up into pressures close to 200 millimeters of mercury. That is a very high pressure for those contractions, and that's what you see in nutcracker esophagus. Our last motility disorder is diffuse esophageal spasm. This condition is caused by impaired inhibitory innervation to the esophagus, and for this reason patients develop excessive simultaneous contractions of the esophagus, leading to symptoms. Because this is a motility disorder, it can lead to dysphagia for solids and liquids. It's also associated with retrosternal burning similar to GERD. It also can cause chest pain that mimics angina, and so in my field of cardiology, one thing that's always in the differential for a patient with chest pain is esophageal spasm. If you perform endoscopy, it will be normal, and the diagnosis is made by esophageal manometry, which will show diffuse high-pressure contractions in the esophagus. Shown on this slide is an example of the manometry findings in diffuse esophageal spasm, and notice that in the middle and lower esophagus, you have diffuse sustained high-pressure contractions. That is consistent with diffuse esophageal spasm. You can also make the diagnosis of esophageal spasm through a barium esophagram. If you put contrast in the esophagus during a symptomatic attack, the classic finding is that the esophagus will take on a corkscrew appearance from diffuse spasm. And that's what's shown in this slide. The esophagus is diffusely spasming or contracting, and that's making the contrast take on this corkscrew-like appearance. In terms of treatment of esophageal motility disorders, we talked about achalasia already. It has its own unique set of treatments. But for hypertensive peristalsis and diffuse esophageal spasm, the treatments are the same. These conditions are treated with smooth muscle relaxants and proton pump inhibitors for GERD. The first-line drug treatment to relax the muscles of the esophagus is the calcium channel blocker diltiazem. This is a drug that's also used for treatment of hypertension and in other cardiac conditions. There are some alternatives if patients can't tolerate the diltiazem or if the diltiazem doesn't work. You can use nitrates like isosorbide dinitrate. Sildenafil has some effect. And as we talked about earlier for achalasia, in other motility disorders you can also inject botulinum toxin into the esophagus to try and relieve the pressure generated by peristalsis. Let's talk about a Zenker's diverticulum. This is a picture of what a Zenker's diverticulum looks like on the screen here. It's a protrusion of portions of the esophageal lining outside of the esophagus to form a diverticulum. It occurs at a location called Killian's triangle, also known as Killian's dehiscence. This is where the esophagus and the pharynx come together. It's considered part of the hypopharynx, and it's just proximal to the upper esophageal sphincter, just above that location. What happens in Zenker's diverticulum is the mucosa and submucosa herniate through the muscular wall of the esophagus. And the reason this happens is usually because patients have chronic swallowing problems. If the cricopharyngeal muscle does not relax to allow food to pass, this will lead to difficulty swallowing, and patients will work harder and generate high pressures in the pharynx to force the food down, and over time this can lead to a herniation and formation of a diverticulum. The symptoms of Zenker's diverticulum include progressive oropharyngeal dysphagia and regurgitation of undigested food. Because the diverticulum is located in the hypopharynx, patients usually have symptoms consistent with oropharyngeal dysphagia, and usually it's to solids only. This is a structural swallowing problem, and therefore, like most structural problems, the dysphagia is usually to solids only, not solids and liquids. But then the key feature, especially in board questions, to help you recognize a Zenker's diverticulum case is regurgitation of undigested food. Food can get stuck in the diverticulum and then come out later, and the patient can regurgitate it. There can also be halitosis or bad breath from food trapped in the diverticulum. The diagnosis can be made by barium esophagram or by endoscopy. Usually an endoscopy is done first to exclude an upper esophageal malignancy. Sometimes the Zenker's diverticulum can be seen on endoscopy, but not always. They are sometimes missed. So if the endoscopy is negative and the history sounds like a Zenker's diverticulum, then a barium swallow can be done, and that usually makes the diagnosis. On the screen is an example of a barium swallow of a patient with a Zenker's diverticulum. You can see this outpouching here in the lower neck where contrast is filling the diverticulum. And the treatment is to resect the diverticulum. This can be done as an open surgical procedure. There are also endoscopic approaches so that the diverticulum can be resected that way. Let's talk about esophageal webs and rings. These are extensions or protrusions of the mucosa of the esophagus into the lumen. This is a picture of a web shown here. These are eccentric membranes, meaning they don't completely surround the lumen. These are more common in the upper or proximal esophagus. This is a ring here. It's a concentric extension of the mucosa. These are more commonly found distally in the esophagus. Many patients who have webs and rings are asymptomatic, but they can obstruct the movement of food, leading to either food impaction or leading to dysphagia, usually for solids. The diagnosis is usually made by endoscopy, although it can also be made by barium swallow, and the treatment is with endoscopic dilation. You can dilate the esophagus and it will essentially push the web or ring into the wall of the esophagus, and therefore it will no longer be able to obstruct food. A Schottky ring is the most common type of esophageal ring. These develop distally in the esophagus just like most rings, but they occur at a specific spot called the squamo-columnar junction. This is where the squamous mucosa of the epithelium converts to columnar mucosa. So in these rings, the proximal portion of the ring has squamous mucosa, and the more distal portion has columnar mucosa. This is a picture of what one looks like on endoscopy. Shown on the right is what one looks like by barium esophagram. You can see this narrowing in the distal esophagus. That's evidence of the Schottky ring. And Schottky rings, just like all rings, are a common cause of dysphagia to solids. This is a structural lesion, not a motility problem, so it usually presents with dysphagia to solids. Liquids can usually move past the ring. There's a rare condition called Plummer-Vinson syndrome that you should know about for your boards. This is a rare, poorly understood condition in terms of its etiology, but it presents as a triad of iron deficiency anemia, dysphagia, and esophageal webs. These patients also classically develop a beefy red tongue, which is glossitis. This is because of damage to the tongue mucosa layer from low iron. This leads to exposure of blood vessels, which makes the tongue bright red. So in a board question, this is probably going to be described in a middle-aged white woman who has dysphagia and endoscopy showing presence of a web. She will also have iron deficiency anemia and a beefy red tongue. And the treatment for this condition is to treat the iron deficiency anemia and to treat the esophageal web just like you usually would. But what you need to be aware of is that patients who have this condition have a high risk of esophageal squamous cell carcinoma. Much like webs and rings, another structural cause of dysphagia to solids is the presence of esophageal strictures. This just means a narrowing of the esophageal lumen. Usually esophageal strictures are caused by long-standing GERD, and when they're caused by GERD, they're called peptic strictures. The diagnosis can be made by endoscopy. This is a picture of an esophageal stricture on the screen here, and it can be hard to appreciate this, but the lumen of the esophagus here is simply narrower than it should be, and that's because of long-standing inflammation causing growth of tissue into the lumen of the esophagus. And the treatment of esophageal strictures is the same as the treatment for esophageal webs and rings. That's with endoscopic dilation. Let me make a brief point about the workup of dysphagia in general, especially as it pertains to board questions. In actual practice in the United States, most cases of dysphagia will be referred for endoscopy first. That's because you want to know that the esophagus is structurally normal, and you want to make absolutely sure you don't miss a cancer. In board questions, however, they will sometimes describe a classic example of a subtype of dysphagia, and they will ask you for the best test. And in that case, the answer is not always endoscopy. So for example, as we've already discussed, if they describe a case of oropharyngeal dysphagia, the best test is a barium esophagram, because usually you cannot make the diagnosis of causes of oropharyngeal dysphagia from endoscopy. If they describe esophageal dysphagia to solids only, then that suggests a structural cause of dysphagia, and endoscopy is the right choice in that situation. If they describe progressive dysphagia that begins with solids and progresses to also include liquids, that suggests a malignancy, because malignancies steadily narrow the lumen of the esophagus. So in this case, endoscopy is also the best test. But if they describe dysphagia to solids and liquids at the onset, then that suggests a motility disorder, And in these cases, the best test is manometry or a barium esophagram, as we have discussed. Let's talk about infectious esophagitis. This can present with odynophagia and dysphagia and also sometimes systemic signs of infection like fever. Candida esophagitis usually occurs in patients who are immunocompromised in some way. It leads to white membranes in the esophagus, and if you biopsy these, you will see pseudohyphae on the biopsy. And this is a picture of esophageal candidiasis shown on the screen here. Herpes simplex 1 usually causes oral herpes, but it can involve the esophagus. When this happens, patients develop symptoms of esophagitis, and on endoscopy, the classic finding is described as punched-out ulcers. This is a picture of what it looks like on the screen here. And lastly, cytomegalovirus can cause esophagitis, usually in patients who are severely immunocompromised from AIDS with a very low CD4 count, less than 50. And the classic finding on endoscopy in a patient with CMV esophagitis is the presence of linear ulcers. Infectious esophagitis often comes up when treating immunocompromised patients with HIV. In this group, it will present in the usual way as odynophagia or dysphagia. Candida is the most common cause, and so for this reason, if patients have mild symptoms or they have evidence of oral thrush, which is Candida infection in the mouth, then usually they're treated empirically with fluconazole, which is the treatment for Candida. Usually in situations where the symptoms are mild or there's evidence of thrush, no endoscopy is done. In contrast, if the symptoms are severe, especially if there is no evidence of thrush, that's when endoscopy usually is done to identify the specific cause of esophagitis so it can be treated. And shown on this slide is a table that you should know for your board summarizing the findings on endoscopy which indicate the different causes of esophagitis. So as we talked about in the last slide, if there are white plaques, that suggests Candida esophagitis and the treatment is with fluconazole. Linear ulcers are the finding in CMV esophagitis and the treatment is with ganciclovir. And if you see punched out ulcers or vesicles, this suggests HSV infection and the treatment is with acyclovir. Eosinophilic esophagitis is an allergic reaction involving the mucosa of the esophagus. This leads to symptoms of esophageal dysfunction, including dysphagia. On endoscopy, there are lots of different abnormalities that have been described, but the hallmark is a biopsy showing eosinophil predominant inflammation. Normally, there are no eosinophils found in the mucosa of the esophagus, but if you look at this slide on the screen, this is a patient with eosinophilic esophagitis. There are lots of eosinophils. I've zoomed in on them so you can see them up close. Importantly, eosinophilic esophagitis is a diagnosis of exclusion. You have to rule out other causes of esophagitis, especially GERD. The diagnostic criteria for eosinophilic esophagitis require that the patient has symptoms of esophageal dysfunction, a biopsy showing eosinophils, and no other cause of esophagitis, meaning no evidence of GERD or infectious esophagitis. The classic clinical scenario of eosinophilic esophagitis to know for your boards is a patient who has dysphagia and a poor response to GERD treatment with proton pump inhibitors. When patients initially develop eosinophilic esophagitis, they sometimes can appear to have GERD, but they won't respond to proton pump inhibitors because their inflammation is not caused by acid in the esophagus, it's caused by eosinophils. So in patients who don't respond well to GERD treatment and who have dysphagia, they are often referred for endoscopy, and when you do a biopsy, you will see evidence of eosinophils. It's high yield for your boards to know that the first-line treatment for eosinophilic esophagitis is dietary modification. Many patients with eosinophilic esophagitis have food allergies, so you can refer them for food allergy testing and then do an elimination diet where you remove the foods they are allergic to. If you do this, many patients' symptoms will get better. In terms of medical therapy, patients can also be treated with a fluticasone inhaler. Fluticasone is a glucocorticoid. It can be sprayed into the mouth and swallowed, and that will suppress inflammation in the esophagus. Earlier in this video, we talked about the acute onset of dysphagia from food impaction, but you should be aware that many patients who have one episode of food impaction can have additional ones. This happens about 10 to 20% of the time, and many of the patients who have recurrent impactions have some underlying esophageal disorder. So in order to prevent recurrence in a patient who has food impaction, you often do additional tests or treatment. Some of the things that can be done are listed on this slide. So a biopsy for eosinophilic esophagitis can be done. If you identify a stricture or a Schottky ring on endoscopy, that can be dilated. And then in patients in whom the endoscopy appears entirely normal, they are often evaluated for an esophageal motility disorder. And hopefully this all makes sense to you after what we've been through now. All these things predispose to food impaction, and so in a patient who has had one episode, you want to check for these and treat them if they're found. I'll finish this video by talking about two acute onset traumatic injuries that can occur to the esophagus. The first one is a Mallory-Weiss tear. This refers to damage to the esophageal mucosa at the gastroesophageal junction. This is a picture of what it looks like on the screen here. You can see that there is blood and a tear in the esophageal mucosa. When this happens, it leads to painful hematemesis. Patients will vomit blood and report epigastric pain or sometimes pain in the back. Often this occurs in patients who have a history of severe chronic vomiting, for example, patients with heavy alcohol use or patients with bulimia. This can also sometimes be iatrogenic. When a nasogastric tube is inserted, it can tear the esophageal mucosa. The diagnosis is made by endoscopy, and the treatment is first of all with proton pump inhibitors. With this therapy alone, sometimes the tear will heal. If the tear doesn't heal or if there is severe bleeding, there are endoscopic therapies as well that can be used to stop the bleeding. So a Mallory-Weiss tear is a tear in the mucosa of the esophagus from severe vomiting. More serious than that is what's known as Boerhaave syndrome. This refers to effort-related transmural rupture of the esophagus. It's called effort-related because it's not caused by trauma. Traumatic rupture of the esophagus is a different condition. Effort-related means it's caused by severe vomiting or retching. And so you can think of this like a severe version of a Mallory-Weiss tear. Instead of just a tear in the mucosa of the esophagus, now you have rupture through the entire esophagus. When this happens, air will exit the esophagus, and you can see it in the mediastinum on X-ray. This is called pneumomediastinum. If you look at this image on the screen, you can see this line, which is the border of the mediastinum, and you can see this black space beneath it. That's evidence of pneumomediastinum. Also in Boerhaave syndrome, air can enter the skin under the neck, and this can lead to a finding called subcutaneous emphysema, where you can press against the skin of the neck and feel bubbles beneath your fingers. Also, when there's rupture of the esophagus, gastric contents can enter the mediastinum. This can lead to severe chest pain, and also there can be dysphagia. Boerhaave syndrome is suggested by clinical features and X-ray. So the clinical features are a patient who has a history of severe chronic vomiting and retching, and the X-ray can show pneumomediastinum. To establish the diagnosis, the test you want to order is called a contrast esophagram. This is similar to the barium esophagram we talked about earlier, but you don't use barium, you use a different contrast agent. And the reason this test is done is because you can see the contrast leaving the esophagus, and that will show you the exact location of the perforation. The contrast agent that is used is called gastrographin. This is a water-soluble contrast agent, and it's used instead of barium because barium will cause inflammation when it leaks out of the esophagus into the mediastinum. That doesn't occur with gastrographin. Shown on the screen is a picture of a contrast esophagram from a patient with Boerhaave syndrome. The contrast should be filling the esophagus, forming a tube, but you can see it spilling outside into the mediastinum. As an alternative to the contrast esophagram, you can do a chest CT. This will often show edema in areas of the esophagus where there's damage, but it's not as good at identifying the precise location as a contrast esophagram. And the treatment is to make the patient NPO. You administer antibiotics because bacteria can get into the mediastinum. You administer a proton pump inhibitor because when you suppress acid, sometimes the damage to the esophagus will heal. And then beyond these things, surgical repair is often required in some cases. And that concludes our module on esophageal disorders.